Okay, thanks very much for coming back, everyone. Ready to go now for the last session of this really interesting and diverse conference. And so the first speaker is Hans Eriksson, who's going to speak to us about dose-finding study of prolonged-release oral ketamine formulation. Thank you very much.
Thank you. Can you hear me well in the room? Yeah. Okay, so my name is Hans Eriksson. I'm the Chief Medical Officer of Ketabon and also of one of our parent companies, HMNC Brain Health. Very happy to be here. It has been a couple of very interesting days, good discussions, and a very diverse agenda, so I really appreciated that. I will move here and yes, so here are the people who have been working together to deliver the data that I will present today. There will be some other data from a recently published paper as well. So you can see these persons come from two companies, the two founding companies of Ketabon. One is Develco, a Swiss pharmaceutical formulations expert that have developed the compound we are working with. And the rest of us come from HMNC Brain Health. We are a Munich-based pharmaceutical company. We have 3 antidepressants in clinical development. One vasopressin blocker together with a companion diagnostic that is halfway through phase 2. One CRH blocker with a separate genetic companion diagnostic that will go into phase 2 later this year. And we also have a prolonged release oral formulation of ketamine, and that's where I will stay this year. This presentation. It will not take a year, I can promise you that. I think these days have been, as I said, interesting. We've spoken a lot about efficacy of ketamine. We've spoken about the dissociative effects that may have beneficial components, but may also be problematic. So I hope I'm not ruining the show now by saying that our objective is to develop an efficacious ketamine-based antidepressant that is largely devoid of dissociative side effects. And this may sound too good to be true, but I think there is a path forward, and I will take you through what we have done so far. First, some disclaimers, conflict of interest, and then a couple of questions. Is it possible to develop a ketamine-based antidepressant that lacks the characteristic side effects? We're talking about dissociation, hemodynamic effects, sedation. So is the NMDA inhibition really necessary? I think this has been a topic that has been debated extensively over the recent years. Are the NMDA-mediated effects like dissociation a necessary component to achieve the antidepressant efficacy? And is it possible to develop an antidepressant that is lacking these side effects that in most instances are unwanted? And the approach we have chosen is to go for a novel formulation of ketamine. So we are using a prolonged release formulation of ketamine with a peak concentration occurring as late as 6.5 to 7 hours after administration. The objective was, of course, to get a lower Cmax and a more gentle increase of the gradient, potentially minimizing target effects by inducing some sort of adaptation. And the formulation also has the properties that if crushed, it becomes a sort of a gel that is very hard to use for abuse. So that's where we started. And the first studies that were conducted with this compound were done in pain patients. And they were dosed in doses up to 320 milligrams orally per day, 2 times daily for 2 weeks. So we had already, when we moved this program into the depression space, we had an experience from the compound and use at daily dosing and also dosing in the home setting. So the first study we embarked on was a study that was conducted at University of Zurich in Switzerland. It was Eric Seifried's group and his colleagues that did this study. It's a study in treatment-resistant depression. This study was conducted in inpatients as an adjunctive to standard antidepressants. The objective was to recruit 99 patients, but unfortunately COVID came between. So the study was actually terminated after about 30 patients, and in total there were 27 evaluable patients. So the study was obviously underpowered, and it explored 2 different treatment arms. Let's see, get back. Two different treatment arms. 240 milligrams per day split into 2 doses, or 160 milligrams per day split into 2 doses. So here are the results from this study that were just published. So what we can see here is that there is a separation emerging relatively early, and it is maintained even though at the penultimate visit, all treatment arms go very close to each other. And at the final visit, there is a numerical separation of close to 5 points on the MADRS, but it does not reach statistical significance. This is the ANCOVA analysis that was a primary endpoint. In the MMRM analysis, the separation was closer to 5 points, and the p-value was closer to 0.1. So this was a robust signal, at least, of beneficial effect. Interestingly, the colleagues in Zurich, when I spoke to them, they told me that they are very experienced in treating people with ketamine-based medications, both intravenously and for inhalation, and they didn't see any of the typical side effects that they were used to. So that was a bit intriguing. And this prompted us to take this drug into a larger clinical development study. So we designed a phase 2 efficacy and safety study with a dose-finding component. So this is a study that was conducted in Europe during 1 year, read out in June last year, and we recruited 124 patients in 3 countries in Europe. The medication was given as an add-on to people with treatment-resistant depression. The first dose was given under supervision when we also did some assessments. The remaining doses were taken at home. And after the 3-week treatment period, there was a 4-week follow-up period. The primary endpoint was a change from baseline in the MADRS scale. And here are the demographics of the study, nothing remarkable. Somewhat more females than males, a MADRS severity around 30 points, so a fairly standard study design. And the results are shown here. So we can see the MADRS scores over time, and there are 3 different treatment arms, and the dark green arm represents the high dose of 240 milligrams, in our case given as once daily dosing. And already 7 hours after the first dose, there was about 2-point separation from MADRS, not yet statistically significant, but the separation increased, and at days 4 and day 7, statistical significance was achieved, and the separation was about 4 points. Improvement continued until week 2, and thereafter the improvement since baseline remained relatively stable. We can also see that the placebo arm is also improving, and at the primary endpoint, the separation is just about below 2 points and does not reach statistical significance. But it's interesting to see that there is a maintenance of the benefit over time during the 4 weeks follow-up. There is no tendency for the patients on the high dose to go back. And the low dose, as you can see, is very similar to placebo. These data were supported by a response advantage for the higher dose over placebo, as well as a remission advantage over placebo. So we're quite confident that here we have a robust antidepressant signal, even though the study did not meet its primary endpoint. We are also very interested in seeing the other side of the coin, the side effects. And to assess them, we use the CAD scale, and you're probably all familiar with this scale. It runs from 0 to 92, and a score of higher than 4 is often considered to be of clinical significance. And at each of the assessment time points, there was no separation between active drug or placebo. And I would particularly want to, if I can get this thing to work, focus your attention on the 7 hours values on day 1. This is the anticipated peak concentration of ketamine. And even at this point in time, when the individuals were exposed to ketamine for the first time at peak concentration, the CAD score, the mean CAD score, did not exceed that of placebo. You can also see that there were a slight difference in the number of patients who had a CAD score above 4. So there might have been a minimal signal which somehow is reassuring. There were no findings on vital signs, heart rate, blood pressure, and the safety you can see there were somewhat more TAEs reported in the active arms and some evidence of a dose dependency. There was suicidal depression in one patient in the high dose group and suicidal ideation in one patient in the low dose group. And there were also transient elevations in gamma GT and ALT, or ALT, occurring from week 2 for both groups, but these changes were transient, as I said. When we looked at the plasma concentrations, we found that the parent compound, ketamine, had been metabolized to a large extent. So it's a plasma concentration we drew at 7 hours, coinciding with peak concentration of ketamine. And norketamine and hydroxynorketamine have not yet reached their peak concentrations, but it's already here evident that the contribution of ketamine is dwarfed by the contribution of the metabolites, and we believe that this is a very, very important property of this formulation. So this finding stimulated us to look a bit further into the tolerability, and we decided to do a head-to-head comparison with more of a standard ketamine-based treatment. We were considering to use IV treatment, but we landed on using the only approved ketamine-based treatment, which is Spravato. And we said, let us give antidepressant doses of both compounds. And we did so in a randomized double-blind crossover study with healthy volunteers, about 25 people coming in twice. Each time they got a nasal spray and a tablet. Only one of them contained active substance. And the primary endpoint was the mean score on the CADS to any time during the 24 hours after administration. And the results come out like this. So you can see that the mean score for intranasal ketamine was about 30 points, while it was about 1 point for Ket-01, which is highly statistically significant. And you can also see on the spaghetti plots the individual patient scores here that practically all patients, or I should say participants, who received Spravato had a score above 4, while most patients in the Ket-01 arm did not exceed 4, and most of them are actually hidden in the 0 line here. So since it's a double-blind crossover study, all participants got both doses, so all participants have contributed to both these scales. We could also find a difference in the vital signs. So after administration of Spravato, there was an increase in heart rate, systolic and diastolic blood pressure, peaking somewhere close to 40 minutes, which corresponds to the peak concentration of esketamine. And those changes were generally gone after 4 hours, and thereafter the two treatment arms followed each other. Here we think that we may have a clue to the understanding of these findings, because here we look at the plasma concentrations. On one hand, esketamine and its metabolites in the study, and on the other hand, Ket-01. So the red lines here represent esketamine, with a relatively high ketamine concentration, followed by norketamine, hydroxynorketamine, where the peak concentrations are similar to the original ketamine concentration. While for the prolonged release formulation Ket-01, there is an extensive first pass metabolism, so we don't have much ketamine even at peak concentration, and instead there is an increase in the concentrations of norketamine and hydroxynorketamine. So the entire profile of parent and metabolites has been shifted in a right direction here. So we hypothesize that in a system where, in a situation where we administer ketamine or esketamine rapidly, this leads to a transient and relatively high ketamine peak. It triggers characteristic NMDA receptor-mediated effects, and together with an antidepressant effect that may be mediated through NMDA, but may also be mediated by other mechanisms. While if we administer a prolonged release formulation with a high first pass metabolism, we have a much later occurring peak of ketamine, a much lower concentration at peak concentration, and thereby we can avoid many of the NMDA-mediated side effects. But we have high concentrations of the downstream metabolites, which we believe may mediate the antidepressant effects. So in summary, Ketabon, which is an oral prolonged release formulation, has shown a signal of antidepressant efficacy in TRD with a rapid improvement from baseline. And antidepressant doses of Ketabon show minimal occurrence of characteristic side effects like dissociation. And the antidepressant dose of Ketabon, when compared to the antidepressant dose of intranasal Ketamine, show that there is a clear difference in the emergence of typical NMDA-mediated side effects. We have now treated 136 patients for at least 2 weeks with daily doses of Ketabon, both in the pain study and in our clinical trials in depression. So we are getting more and more confidence that the take-at-home medication, which we use for all these patients, is viable. We have had no problems with the administration at home. And we see a potential to move this compound into a medication that can be developed to be taken at home, which was, of course, the topic of the debate we had on Monday. I was very happy to see that the eventual result was positive, because we firmly believe that this is a possibility. But in this case, I think it has very much to do with a vastly improved tolerability profile. So thank you so much.
Fantastic. Any questions at all? Oh, chap over there.
Thank you for, it was a very fascinating talk. Have you any idea of the safety and overdose of these tablets?
We have not explored it in overdose, of course. I think the formulation in itself is made in a way that even if you crush it and try to overdose, it will become difficult to administer it any other way. So if you take it orally, yes, there will probably happen things if you take, let's say, 10, 15, 20 tablets. So I don't think the oral administration in itself is a guarantee, but we see that with smaller package sizes, I think we can minimize that risk.
Thank you.
Thanks, Hans. It's very nice data. Just a very simple clarification. Why did you choose daily dosing and not something more infrequent?
Yeah, I think the original thinking for going for daily dosing was we wanted to understand how long time does it take with daily dosing to achieve optimal efficacy. And then the original idea was that to thereafter be able to switch to a maintenance treatment. I think with the increasing knowledge of how, for instance, Spravato is being used, I think it may be possible to actually initiate also this treatment with a much less frequent dosing, let's say twice per week or perhaps 3 times per week, first week. So I do not think we are expecting to go in that direction.
Great. Thanks very much. So let's thank Hans. That's great.
Thanks.